বলুন।
Why is the video? Why is the video?
আরে বলুন আপনি।
Kishore, please show the video first.
Show the video, Kishore. Kishore, you are supposed to show a video.
কি হলো? তোরা আগে থেকে রিহার্সাল?
Yes, sir.
Yeah, you are supposed to show a opening video. Good afternoon, everybody. This is the 142nd birth anniversary of Bharat Ratna late Dr. Bidhan Chandra Rai, who is the architect of modern Bengal and also the founder president of Cardiological Society of India. Let us celebrate this day dedicated to the doctors all over the India and resolve to face all the challenges coming in the doctors unitedly. Today we have in our midst Dr. Sanjay Tyagi, Dr. P.C. Roth, Dr. P.K. Dev, Dr. Dhiman Kali, Dr. Amal Khan, Dr. Debabrata Rai,
ডক্টর মৃণাল দাস।
and Dr. Mridul Das. So please, so we'll now move on to the next address, and welcome address by Dr. P.C. Roth sir. Dr. P.C. Roth sir, you are up.
Good afternoon to all of you. Greetings to all of you on the eve of Doctor's Day, and I welcome all of you for the Doctor's Day celebration by the Cardiological Society of India. As you know, this Doctor's Day is celebrated on July 1st every year to honor the significant contribution of physicians, and is dedicated to late Dr. Bidhan Chandra Rai, a former Chief Minister of Odisha, recipient of Bharat Ratna Award, and also the first president who started the Cardiological Society of India and as his first president. Born on July 1st, 1882, Dr. Roy passed away in July 1st, 1962 at the age of 80. The day serves as a tribute to all doctors who dedicate their life to serving humanity while honoring the memory of Dr. Roy. The theme of this year is Healing Hands, Caring Hearts. It emphasizes the dedication and compassion doctors bring to their daily practice and the critical role they play in saving lives. The theme highlights the relentless effort of doctors to provide care and comfort to their patients. National Doctors' Day acknowledges critical role played by doctors in the society, from providing routine medical care to responding to emergencies. Doctors are the backbone of the healthcare system. It's also an opportunity for the public to express gratitude to the medical community. It is a day to recognize the sacrifices of doctors make often at the expense of their own well-being to ensure the health and safety of others that were well depicted during the COVID epidemic. On this day, I urge the doctors to use their knowledge and skill to bring hope and healing touch to the countless individuals in India and all over the world. Your tireless efforts, sacrifices, and relentless pursuit of excellence make the world a healthier and safe place. Long life CSI. Thank you very much. Hello.
Chakraborty.
Yeah.
হ্যাঁ বলুন।
We have in our midst Dr. Suman Chakraborty, Professor, Department of Mechanical Engineer and Sir J.C. Bose National Fellow, Indian Institute of Technology, Kharagpur. Now we move on to the garlanding of the BCO statue at the Indian Heart House.
এখানে ক্যামেরা অফ করো।
Dr. Kishore,
ক্যামেরা
please.
ওইখানে ক্যামেরা দেখা যাচ্ছে, অফ করো।
237 একটা আছে, ওকে দেখে নিতে পারো। 237 ওর ক্লাস কি হবে?
ভিডিও দেখাবো, কিশোরকে ফোন করো।
Kishore, can you please play the another video?
Yes, sir, I'm playing.
কি হবে? ভিডিওটা জাস্ট অন করে দেখাবো।
Okay. Okay. So now we move on to the address by the chief guest, Professor Suman Chakraborty, please.
Very good afternoon to all the experts of the society, and it's a great honor, I would say, and a privilege, and perhaps a bit of pressure on my side that being a non-medical person, I'm being entrusted on giving a chief guest talk in this very important event. So I will beg a pardon if I tell something which is medically not very appropriate, but I would like to share some of my thoughts on what I would imagine as the interface between technology and healthcare, in particular in the context of cardiovascular disease management. I would first share my screen, and let me try to share the slides. Maybe it will be the best. If you could let me know if the slides are visible, then I will make it full screen.
Yes, sir.
Yeah,
visible.
yeah, it's visible.
Okay, so I will make it full screen so that it is bigger. So the central theme of this very short presentation is a bit going backwards. Nowadays, technology is playing such an important role that we are almost getting into an era of technology care rather than healthcare. All what it means is that gone are those good old days, and typically I am remembering this in this occasion of the Doctor's Day, and when we all grew up from our uncles and parents and senior persons who have seen Dr. B.C. Roy himself treating patients. It has been a legend that by looking into the patient, he would come up with some diagnosis. I do not know how much of this is valid for all the cases that he has gone through in his entire life as a clinician, but there is no doubt that he had very, very special clinical
Sir, sorry.
insight.
Actually, the slides are not moving and it's not in full screen.
I'm not moving the slide as
It's not
yet,
in full
so,
screen, sir. It is not in full screen.
It is in full screen in my thing. I do not know. Let me
Can you escape, sir? Can you escape?
Yeah, let me try to do.
Then
here.
again share it. Again make it full screen. Yeah. Now it's
Uh,
no. You have selected screen. You have
okay,
selected only
yeah,
PPT.
so it is, I think it is double sharing something, I do not know.
Yeah.
Uh,
Kindly, can you stop share, sir? Stop share.
Okay, stop share. Yeah.
Select
can you-
share screen. Click share screen and select
Okay.
first option screen and
Uh,
desktop.
Okay,
Then
share screen, the first option, only the screen one, right?
Yeah,
Yes.
screen one, then select share.
Okay.
Yeah,
Uh,
now you can make it full screen, sir. Now it will click on.
Okay, let me see. I made it full screen, but it is coming. I think it's, let me try to do this.
It is now full screen.
Just, okay, so screen. Okay, I present. Now, can you see it full screen now?
Yes, sir.
Now it is full screen.
Okay. That's fine. So I was coming to a point where it has been a legend who, with an outstanding clinical eye, could detect something which perhaps in the modern era will be executed by not just one but a few diagnostic tests combined together. Now, in that way, and more so because technology has become so advanced that it can probe into micro, nano, and even beyond. So a major part of healthcare, therefore, has come towards what we call as technology care. With the advancement of AI, this aspect has been even more emphatic. And this is very much needed if we consider what we see as a scenario in a resource-limited setting. For example, if we consider a country like India, we have about 25% of the facilities extremely centralized at places and decentralized at places, whereas 75% of the facilities which are more centralized and they are located in big cities. And because these 25% of the facilities are at mostly locations which do not have sufficient human resources and infrastructure and other form of support, it means that they have to carry the burden of maybe 75% of the population, but they do not have the physical capability of doing that. So in that respect, technology indeed plays a very important role, and it is a combination of various aspects of technology, starting from telemedicine to diagnostics to therapeutics. All these are being used in a manner which is definitely much more emphatic than ever before. But with everything, there is a challenge that comes up with. I'm giving just a couple of examples which come in our common day life. One is a smartwatch. So the smartwatch gives data, and smartwatch gives certain data which have elements which can be used for cardiovascular screening. But all of you who are high-level experts in this subject will agree that you will rarely even do a basic screening when a patient reports certain smartwatch data. So where is the gap? So this has to be understood very carefully, and the boundary conditions have to be set correctly. I can, in a very light mood, give an example. So a couple of years back, I was traveling in Europe, and my son at that time had the first flavor of using a smartwatch. So he was very excited, and we were traveling by a TGV train in France, which is very fast, and he just kept his smartwatch on. And we traveled about 2 hours, and it was about 400 around kilometers. And his smartwatch gave a reading that, outstanding, you have worked very hard towards that, your health, congratulations. So So all what it means is that it is a use of technology, and the smartwatch in its own interpretation is not wrong. But the whole idea is how can we bring such aspects to clinical practice. So what we have to see here is that we do not have these days physicians like Dr. Bidhan Chandra Ray, who had outstanding clinical assessment and also medical knowledge. But today we have outstanding technologies for diagnostic reasoning and diagnostic screening. So can we combine the clinical assessment, medical knowledge and diagnostic reasoning all together in a way to make a package where AI comes as a tool and it doesn't become or remain just as a technology, it becomes intelligence augmented. So just flipping AI, it becomes IA. So what it does is, it doesn't replace a doctor, but what it does is it replaces, or rather it substitutes. I think the screen is not moving, so that's a problem. Okay, so the whole idea that I was talking about, that the AI or the broader part of the technology, which also may include the physical device, we have to imagine that it is not really the use of the technology that all matters. So there are certain basic questions that we have to answer. Are we paying too little attention to the basics of healthcare access and doctor's wisdom? So someone coming with a headache to a doctor, the doctor will imagine that it could be possibly 1,000 possibilities, starting from a simple migraine to even a brain cancer. But now if you give a search to Google with a headache, typically within 3 or 4 interactions, I see 90% of the cases Google is giving you an alert that you are likely to have a brain cancer. So if we are becoming doctors in that way by looking into these recommendations, it's a problem. So in this exponential use of technology and data, and particularly the aspect that we are spending a lot of money for what we say as sick care, that means people who have already become sick, caring those people, how can we reduce that burden by developing a technology which is a combination of clinical assessment, medical knowledge, and diagnostic reasoning? And that is what I'm trying to talk about today in very brief. So my entire emphasis is that when a patient comes to a doctor, there are certain basic inputs that the doctor will get immediately, like the patient's demographics, the medical history, if it is recorded, otherwise if it is not recorded, at least by interactive dialogue, it can be input at that point of time, and certain body vitals like blood pressure, pulse, oxygen saturation, temperature. These are certain data which very readily in any clinical setting, be it resourced or resource limited, it is possible to organize. So based on that, with the use of AI and training the AI with the kind of wisdom that doctors would have from their knowledge and experience, one can do a first layer of screening, level 1 screening. And this level 1 screening can be done without much of resource. Now, if the level 1 screening tells that there is a red flag or a red signal, then you go for a level 2 screening where you may use some point of care diagnostic technologies, the simple technologies which can be used at point of care. And then after the level 2 screening, if we still have a red flag, which is a combined outcome of the level 1 and level 2, then we can come to a conclusion that these are perhaps more difficult patients to address, and we can direct them to medical specialists. So in that way, in a country like ours, where we have huge load of patients, we can sort of marginalize the loads at each and every level of the screening. So for the screening tests, in our research group, we have developed certain technologies, and for the interest of time, I am summarizing a few. Like we have, for example, a technology which is like a finger prick blood-based point of care test, where you have the lancet as a needle, just like our home blood sugar test, and a strip, a paper strip, where using a technology known as paper microfluidics, the blood drop reacts with reagents which are embedded on the strip in a lyophilized form, that is in a dry form, and the entire test is conducted there, and very importantly, only the smartphone is used to interpret the test. There is no in-between device. So it's a glucometer-free glucose test. So in that way, we are trying to have different tests of this kind, and we have our industry collaborators, Smart QR Technologies, who have taken this technology from IIT Kharagpur, and they have licensed this technology and commercialized this for use. We also have a lipid profile test. I am coming into this perspective because this is a cardiovascular event. So lipid profile is a very important test, and we have a technology which is called as lab on a CD. You see that there is a disc-like, it is basically something which looks like the external CD, which we have with computers. Currently, people do not use that much because pen drive has come. But this is something, if you rotate it and put one drop of blood, it is just like a mini centrifuge. So the plasma will be separated and it will go to different locations. And then at those locations, if you have LDL, HDL, and triglyceride reagents, then LDL, HDL, and triglyceride, it will give the colorimetric reactions. All of that can be put into a simple office scanner. So in that way, we can have all these tests which are done. Now, cardiovascular examination or assessment is not just about such blood tests. There is something which goes on inside the physiology, which is hemodynamics or dynamics of blood flow. In different very vulnerable arteries, like carotid artery, coronary artery, you can have certain blockages, and that can be very, very detrimental. So we have developed certain methods by which you can take the CT scan or MR image from that, and using certain supportive evidence and clinical data, it is possible to construct a simulation platform where we can get the pressure, flow, and resistance, the three important hemodynamic parameters that are very critical for cardiovascular health. So to summarize, we can have a multi-layer decision-making system for cardiovascular analysis. Layer 1, only clinical metadata. It doesn't require much of device. Level 2, it is a bit of device, but available everywhere, like blood pressure, pulse and oxygen saturation measurement, or maybe a simple ECG if it is available. And level 3, essential point of care tests, and all these combined together with the hemodynamic simulation if you have advanced medical image data available. So in that way, it is a multi-pronged approach. That means you do not rely on just one source, but depending on whatever source of medical data is available, you try to analyze, synthesize, and put that into a multi-layer clinical decision support for cardiovascular health. So if you are able to do that, it not just helps the clinician. The clinician is overburdened with patients, so the clinician can use these for screening of the patients, and once that is done, more vulnerable patients can get the attention of the best of the experts instead of everybody flocking into the chamber of the expert to get a solution. So the entire paradigm, what I would say, is from digital health to digital health plus. So it is not just about digital health or digital technologies that come into healthcare, but combining that with the clinical knowledge, wisdom, and the deployment to the last mile. So starting from the input of the clinicians to the input of the technologies, and all culminating into certain applications which can be utilized and applied by minimally trained personnel, resource personnel at extreme resource poor settings. So what I would imagine is the future of healthcare would definitely depend on technology, but it is not technology alone. It is a combination of, we can say, technology, clinical knowledge and wisdom, and social dissemination model, where all these aspects should come in an ecosystem and holistic paradigm. And that is where I think a transformation in community and rural healthcare may be possible. Thank you very much.
Thank you, Professor Chakraborty, for an excellent lecture. At this point of time, to all the audience, we have actually nearly 300 live logins right now. I would like to inform everybody that CSI headquarters is collaborating with Professor Suman Chakraborty from IIT Kharagpur on developing a risk model for predicting coronary artery disease, which will incorporate all the things that we have talked about, the basic clinics, the basic investigations, up to the advanced investigations. We are collaborating, CSI is collaborating with IIT Kharagpur in developing the risk model. Thank you, Professor Chakraborty. Thank you very much.
Thank you very much. And I would express my sincere gratitude to you for inviting me for this program. And we are having another very important program on Doctors' Day at IIT Kharagpur, where we have a very important guest, Dr. Indranil Khan. He's talking about the cancer diagnostics and management. So I would request leave from this particular program. And from my side, I would like to assure and tell all of you that from IIT Kharagpur, our entire team will be there to help any cause which is there for technology for the benefit of healthcare of the common people.
Thank you very much. Thank you.
Thank you very much and goodbye.
Now, we have Presidential Conclave on Cardio, Kidney, Metabolic Disorder, which will be moderated by Dr. Sanjay Tyagi, who is the President-elect of Cardiological Society of India. Amongst our list, we have Dr. P.C. Das, Dr. P.K. Amal Khan, Dr. Manoranjan Mandal, Dr. Debabrata Rai as panelists, and Dr. Mrinal Das as panelists.
Ex-president,
Ex-president কে
past president, যারা আছে তাদের মধ্যেই তো হবে, কি মুশকিল।
না কিছু করার নেই।
Secretary নহি। Ex-secretary।
Dr. Tyagi, you can start our discussion. It will need some.
Good afternoon, everybody. My greetings on this Doctor's Day. I hope you are able to hear me.
Yes, sir. Loud and clear.
Thank you. And I'm seeing the galaxy of the past presidents here on this very important occasion of the Doctor's Day. And we have selected a very important topic that is affecting our generation in this century. That is cardio kidney metabolic syndrome for this discussion. And as you know, there is a close interrelation between these three conditions. And the risk factors are also very closely linked. So today we shall be discussing briefly about these cardiorenal metabolic syndrome and how they interact. And to start the ball rolling, I request one of the most important speakers on this topic, the most learned speaker on this topic, Dr. Mrinal Das, because he has been speaking a lot about the heart failure, diabetes at the international forums and with excellent lectures. So can I start with Dr. Mrinal Das on this very important discussion?
Yes. I think this is a very, very relevant problem which has been picked up by Cardiological Society of India at the very important day that is Doctors' Day. I'm thankful to the society for inviting me as the past president of Cardiological Society of India in this forum meeting. as you know that cardiovascular disease is basically a metabolic disorder. It can be manifested in a different way, but most importantly, the metabolic disorder is manifested in the form of obesity, in the form of obstructive sleep apnea, in the form of hypertension, diabetes mellitus, then hypertriglyceridemia and hypercholesterolemia as well. And along with that, there can be other phenotypic problems in the form of the central obesity, truncal obesity, and it may be associated with, the problem of chronic kidney disease, which is coming in a very big way, and that is going to affect our whole prognosis in a very, very definitive way. So cardiometabolic kidney syndrome or cardiorenal metabolic syndrome is a conglomerate of various disorders, and those disorders should be taken care of in the right perspective by taking the metabolic syndrome as a central focus, where lifestyle modification and other modifications, which will be discussed at later point of time in a very, very definitive way.
Thank you, Dr. Das. I think he has very well highlighted that these three conditions are very interconnected: heart, kidney, and metabolic syndrome. These disorders often coexist and exacerbate each other due to their shared risk factors like hypertension, diabetes, and obesity. Epidemiological studies have consistently demonstrated that the cardiovascular, kidney, and metabolic disease often overlap and coexist even in the same patients. The prevalence of kidney metabolic syndrome is rising globally and driven by an increasing rate of obesity, diabetes, and hypertension, particularly in India, which is called the diabetes capital of the world, and the most common cause of death in our country is also coronary artery disease. So it is very relevant to our country. Often it has also been seen that patients with heart failure have high incidence of type 2 diabetes. About the 20% have type 2 diabetes in those patients with heart failure. Similarly, type 2 diabetes is associated with 2 to 4 higher fold risk of development of cardiovascular disease. So these conditions are very closely interrelated. So I will throw next. Anybody from the galaxy of this important cardiologist available here?
I think Dr. Prishirath is there.
Dr.
Dr. Prishirath should be.
So, Dr. Rath, may I request you to highlight what are the factors that predispose individuals to these disorders, and how do family history influence these assessments?
See, basically, combining these three conditions makes it very important, because most of patients, as you told clearly, that many patients, the three coexist. So what it requires is a multidisciplinary approach, and multidisciplinary approach involves diabetologist, cardiologist, and nephrologist, because all these metabolic conditions and diabetes, hypertension, coronary artery disease needs to be treated with a combined team, and most of the time it's genetic. It's known that central obesity, diabetes, hypertension are genetic predisposition, and many of the coronary artery genetic. So it also involves strong family. You have to take a history, family history, and this has to be treated at a very young age, because many of them develop this disease in a very young age. So people with family history of diabetes, hypertension, premature coronary artery disease, they have to be screened at a very young age, and they have to be followed up. The emphasis should be early diagnosis and prevention.
As Dr. Rath has highlighted, that these should be diagnosed as soon as possible. So may I request you, any of those present here, so how can we find out the early warning signs and symptoms that indicate the onset of this cardio-kidney metabolic syndrome, so that to identify early and prevent the development of complications due to these diseases. Any from the galaxy of the
Dr. Amal Khan. Dr. Amal Khan, please. You know Dr. Amal Khan is in past president and
Dr. Taggi,
how to identify these cardio-kidney metabolic syndrome as are at the earliest?
cardio-kidney metabolic syndrome from the biological markers, from genetic predisposition, from other metabolic factors, from insulin resistance, all these factors taking into account. You have to take into account that whether it is a cardiac problem associated with renal or renal problem associated with cardiac. And any of the cardiovascular system disorders, even renal disorders, the cause of death is major cardiovascular problem. You cannot find many patients with chronic renal failure which are dying, and most of the times renal transplantations, regular dialysis can help them, but they die of cardiovascular problem. More than 60% of the mortality of the renal failure patients die of cardiovascular problems. So they are very intimately related, and these intimate relations arising from the original pathophysiology of these two disease conditions at a time. Number one is insulin resistance. Number two, hypertension. Number three, diabetes. All these factors taken into consideration, they are all predisposed to either cardiovascular failure and they are all predisposed to renal failure as well. And which of the systems will be manifested, major manifestations will take into account, that is genetic predisposition. What we found that many people having cardiovascular problem with rising urea and creatinine level and GFR is coming down. And many people with renal failure to start with, they did not have any cardiovascular problem earlier. And this gradually process to cardiovascular domain, and there is cardiovascular failure. And the pathophysiology of both of them are intimately interrelated. And they are metabolic problems, insulin resistance, and all these things. So that is the problem, that you have to, it is a generalized atherosclerotic cardiometabolic problem. And that is why I think that nowadays, as you know, that SGLT2 inhibitors and these newer molecules, which are very effective in managing both these situations at the time. And that's why they are very much effective also in these two situations. Somehow there is an interface between renal failure and cardiac failure. And this interface we have to tackle.
Thank you, sir, for highlighting this very close interrelation between these three pathophysiologies, which are very closely interrelated to each other. Now we have biomarkers which can diagnose these disease and help us to treat these conditions and stage these conditions in So, Dr. Mandal, may I ask you, what are these biomarkers which can help us in the diagnosis of diabetes, prognosis of diabetes, and heart failure, and in the chronic kidney disease? The role of biomarkers, and what are these biomarkers which can help us?
Yes, sir. Patients having long-standing diabetes more than 5 or 10 years and hypertension, we should screen these patients for initial renal control like urea creatinine and albumin creatinine ratio, which may give whether the patient has microalbuminuria or not. If a patient has microalbuminuria, that is an onset of diabetic kidney disease or hypertensive kidney disease, which may more prone to atherosclerotic cardiovascular disease too. So we have to screen every patient for ACR, albumin creatinine ratio, 1. And we should estimate the GFR. Sometimes we get the creatinine in the normal range, but GFR
I would like to, Dr. Taggi, I would like to add a few more.
Yes, sir.
Which are coming in a very, very important way. One of them is cystatin C.
Yes.
Estimation of cystatin C. They really give good indication about the eGFR as well as the early detection of the kidney disease very early. And apart from this, galectin is also another biomarker which can give impression about both the involvement of the heart as well as kidney together. So these biomarkers are coming in a greater way, and we are using them quite frequently nowadays.
Sir, you have been speaking a lot about these heart failures in the international forums. What are these monitoring devices which are helpful in the treatment of these heart failure patients in early stage and during their management? Heart monitoring devices, the remote monitoring devices I'm talking about.
This monitoring can be divided into different segments. Out of this, self-monitoring is the best one, and second is monitoring by the health system, that is by doctors, nurses, and others, and third is the remote monitoring. So these three ways of monitoring can be done. Self-monitoring, if we make available some kind of cards known as health card or cardiac card, then they will put the weight, then how much fluid intake they are doing, what are the medicines they are taking, whether they have taken some medicines or not. So they can go on ticking and measuring the weight, blood pressure, heart rate. All these can be monitored by the person himself or herself, and that gives a lot of value to the whole management of the patient of heart failure. And in our country, where the resources are very poor or resources are very less, it is of utmost importance. Second is, of course, the doctors and nurses. These ASHA workers, they can also help in managing the patient by whatever are the methods by self-monitoring that are being followed. The ASHA workers can also give some help. And third factor is the remote monitoring, which is again coming in a very, very big way. First is there are certain devices which can give indication. Say Dr. Shubham Chakraborty, he has already mentioned about the Apple Watch. So if there is sudden tachycardia or atrial fibrillation or like that, it indicates that there are dysfunction at the atrial level or left ventricular end diastolic pressure level. Same way, there are certain devices which can be implanted as well in the heart, which can monitor the fluid intake or rather fluid overload, and thereby there can be warning signal. So there are a lot of things which are coming in a very big way for monitoring the patients of heart failure, and we'll have to take up the challenge and we'll have to deal with the challenge adequately.
Yeah.
Thank you, sir, for highlighting this.
Just a moment. We have two EC members on net. Dr. Pulala Chandrasekhar, can you unmute yourself? Unmute yourself, please. We have Dr. Pulala Chandrasekhar
And Dr.
Dr. P.K. Asakar. Dr. P.K. Asakar, sir, please switch on your video. You are not visible. So you can direct, ask them to participate in the discussion. Dr. Tyagi.
Thank you, sir. I think we have come to the stage where we are diagnosing and we have understood what are the role of biomarkers in the treatment of these interrelated conditions. Now, because these conditions are closely interrelated and we want to manage them first by lifestyle measures. So may I ask Dr. Ashokan about the lifestyle measures in the treatment of this cardio-kidney metabolic syndrome?
Also, Dr. Satyan Tiwari is also there.
Okay.
Dr. Satyan Tiwari, P.K. Asakar, Dr. M.S. Ravi, Dr. Subhash Asakar.
Ashokan, can you hear me?
Yeah, Dr. Asakar.
Dr. Ashokan, you are muted.
Dr. Asakar, you are muted.
You are muted. Kindly switch on your audio.
Audio, you are
Good evening, sir. Happy Doctor's Day. Good evening, sir.
Dr. Chandrasekhar.
Good evening, sir.
Good evening.
Yes, sir.
Dr. Chandrasekhar, would you like to answer this? The
Today we
life.
have attended BC Rai at the Karnool Medical College.
Yes.
So installed a statue at Medical College 1 year back. Our batch has donated. I think I have kept in the WhatsApp. I think this is a good sign. I will come to the NIC, sir. We'll meet you there.
Okay. Now, may I ask you the lifestyle measures which we can use in these patients who have been recently diagnosed with cardio-kidney metabolic syndrome? The
Yes,
lifestyle measures.
But most of the problem is with the hypertension, there is a misnomer in the people that once they take medication, they have to take a lifelong. I think we have to educate them, the public particularly, they should take regular medication apart from the lifestyle modifications. And most of them, they will stop after 1 month, sir. That is a problem. And the blood pressure variability is one which is increasing the morbidity and mortality among the cardiovascular diseases, sir. So I think we have to still further educate the people regarding this. And apart from lifestyle modification and drugs and all, definitely it plays a major role.
Thank you, Dr. Chandrasekhar. And may I request Dr. Ashokan, please unmute yourself again.
Yes, sir.
What is the heart healthy diet that
Yeah.
you will recommend to your patient coming with cardio, kidney, metabolic syndrome? Usually they are obese, they are diabetic, they often have cardiovascular disease. What will be your recommendation to your patient who comes to you for treatment? Dietary recommendations.
Most important is, the lifestyle changes already we discussed. So most important thing is the diet thing. If patients are hypertensive, then salt restriction is a one important factor, because hypertension is a major comorbidity associated with this CAD or heart failure, whatever, along with the CKD patients. Apart from the, we already, a patient is diabetic, we have to restrict the, we have to avoid sugar. And for patient with all these patients may be having atherosclerotic disease also, sir. So most important thing I think is the salt in these patients, because maybe having volume overload, hypertension, and these patients. Apart from such saturated fat and other things, anyway, you recommend as a preventive measures. So
May I now,
Yeah.
Dr. Dev,
One moment, sir. Right now, I have received information from our technology experts that we have 425 live logins to this program. 425. Now, we have Dr. Satyan Tiwari and Dr. M.S. Ravi. Dr. Satyan Tiwari, Dr. Tiwari, please come online.
Dr. Tiwari.
Yes. Good evening, sir, and happy Doctor's Day to everybody.
Thank you for joining. I think you must be very busy in organizing work.
Sir, it's going on, sir.
So how do you make your patient who comes to you with cardio, kidney, metabolic syndrome, that is that diabetic patient, cardiovascular disease patient, how do you manage their lipids?
Sir, first of all, we ask them to get extended lipid profile fasting samples and see whether other than the routine total cholesterol, HDL, LDL, triglyceride, VLDL, non-HDL cholesterol is equally important, and so is the other non-conventional risk factors like lipoprotein A, APO, and ApoB, and its ratio is equally important, because the reason being getting their extended lipid profile is that most of these proven coronary artery disease patients have a low LDL, say like 100 or something like it. So if you have to treat and decide the treatment duration and the dose of the statins, one should assess their apolipoprotein B. So that is equally important to see how much dose you want to escalate and how long you want to continue such patients. Other than these, the other HbA1c markers, the renal parameters, the kidney size, all these parameters one should undergo and advise these patients to monitor their lipid profile.
Can you throw some light on the newer anti-lipid agents apart from statins?
The other the other inhibitors, they are working on it, and especially the lipoprotein A inhibitors, which is now is still not commercial here, available in India. So there are 3-4 molecules on which the trials are there, and how much it has to be used and how long is to be seen.
So most importantly, the statins are the mainstay of treatment of these, apart from their diet
As of now, in combination as well.
and lifestyle measures. Lifestyle
Yes.
measures involves also improving their physical, asking them to improve their physical activity, avoid smoking, reduce alcohol intake, and maintaining a healthy diet and regular physical exercise. So what is
Lifestyle.
We have Dr. Kajal Ganguly with us. So I think Kajal will take the, you can direct your next query to Dr. Kajal Ganguly. We are sitting there.
Dr. Kajal for joining this important symposium? I think what is your management of these patients who come to you with both kidney and cardiac?
Yes. Yes. Now,
Often these patients have renal failure as well as
Yes,
they come to you for management of their coronary artery disease. Patient with renal failure coming to you for management of coronary artery disease.
Management chronic
Yes.
CAD in
yes, these patients, there is if they have got cardiorenal metabolic syndrome as a part, having this renal dysfunction along with these cardiac problems. Now there are drugs. Now the drugs which is most commonly used is SGLT2 inhibitors, which prevents or delays the heart failure. Also, it can reduce the heart failure incidence. Side by side, it reduces the renal dysfunction, deterioration of renal dysfunction. Second drug is the Kerendia, that is the Finrenone. Is coming in a big way. Finrenone prevents the renal fibrosis, and thereby it reduces this deterioration of renal function. Its efficacy in heart failure and coronary artery disease is being evaluated, and we shall have these study results in near future. And this is a new molecule which will help in preventing both these conditions.
Okay. Dr. MS Ravi, can you turn your video and audio? Dr. MS Ravi?
Dr. MS Ravi?
the time over.
So we have time for a last couple of questions. Last question to Dr. Devabrata Roy, please.
Sir, what is the role of the environmental pollutants in cardiovascular disease?
Yeah, Dr. Tyagi, I was listening to all these discussions. So, the latest American advisory, it was promulgated by the president of AHA on CKMD. One of the important points is the social determinants, not only social, economical, and geographical determinants of influencing the outcomes of CKMD. It is an important issue, and one of the issues under that is air pollution. As we know, that the current state of India is one of the most polluted countries in the world, with many of the cities, not only the cities, the entire Gangetic belt, the PM 2.5 level is at a danger, has crossed the danger point in most parts of the year. And this is obviously, this can cross the lung barrier, spread into the bloodstream, can affect multiple organs. And that is one of the ways of mechanism behind production of CKMD. So air pollution is an important issue, and Cardiological Society of India has taken interest of late on mitigating air pollution, and we are trying to address those issues. Until now, the other thing, as the air pollution has demonstrated, the basic problem underlying CKMD is a bidirectional relationship between different diseases. Like there is a bidirectional relationship between cardiac and renal components. There is a bidirectional relationship between adiposity and cardiac problems. And the baseline or the basic mechanism is inflammation. And as we know, we are discussing you are just asking what are the latest lipid lowering drugs. So it is interesting to note that whatever we have right now in our armamentarium, be it the PCSK9 inhibitors or the siRNAs or whatever drugs are coming, all the trials with such drugs has shown that it is not only LDL lowering that matters. The main thing matters is the residual inflammatory risk as reflected by HSCRP. So what I believe in all these scenarios, the total CKMD conglomerate, probably down the line in next 3-4 years, we may have inflammatory markers and inflammatory basis for CKMD.
Thank you, sir. I think that was a very important overview of the role of these pollutants and do we have time for any further questions or can we?
I think we should call it a day now. Our time is up. And today we had a very important session on cardio-kidney metabolic syndrome or complex, whatever way you call it, and the way it is going to affect our health, our future generations' health should be a matter of big concern. And I think with the leadership of Dr. P.C. Rath and yourself in the coming years, we should be able to move forward in the proper direction. And right now, as you all know, India is not only one of the most polluted, and it is one of the laziest country in the world. We have per capita, we do the least amount of physical activity. So this is an aspect where we should concentrate on improving the environment, improving the activity level. Thank you, everybody. Thank you, everybody. Have a good day.
Thank you, sir.
Bye.
Thank you, everybody. Thank you very much for joining.
Hello.
Thank you.
Of course.
Of course. Good day.
Good day.
Good day.
Thank you, sir.
Thank you.
Limited.